All right. Hi, welcome everyone here tonight. Looks like, outstanding attendance. A lot of people signing in as we get going here. My name is Sean Scanlon, and I'm going to be serving as moderator here tonight. I work with Treese Medical, the company that manufactures and produces the Lapiplasty system. So we're excited to have an educational and interactive discussion here tonight with Dr. McAleer. And this is a little special. We have one of his Lapiplasty patients on tonight, Laura, who'll be joining us to offer her perspective on going through the procedure and her recovery process as well. So this is the third webinar in our series. And for those that have been on some of the earlier ones, we're going to continue to offer these webinars in a series format. So look for these and continue to join us on a monthly basis to get in and learn more about bunions and the Lapiplasty procedure. And at any point here tonight, if you do want to search for surgeons local in your area, we have Lapiplasty surgeons trained all across the country. You can go to alignmytoe.com, and in the upper right, you'll see a Find a Doctor search box. So at any point, if you want to see surgeons that are nearby you that are trained, feel free to go to alignmytoe.com and search for a surgeon there. All right, so we'll get going here tonight, and we're very lucky to have Dr. McAleer as the surgeon speaker on the webinar here tonight. And just a quick intro on him. So Dr. McAleer is a board certified podiatric surgeon in Jefferson City, Missouri. He's received his medical degree from New York College of Podiatric Medicine, where he graduated in the top of his class. And he completed his residency at Mount Sinai Hospital in New York City, which is one of the top hospitals in the country. Dr. McAleer entered his private practice in 2006 and has gained a lot of experience in all aspects of foot and ankle and lower extremity surgery. He's a diplomat of the American Board of Foot and Ankle Surgery and is a fellow of the American College of Foot and Ankle Surgeons. And Dr. McAleer has authored many publications in medical journals. He's lectured internationally, and he currently serves as a medical device consultant. And one of his roles in the medical device world is as a design surgeon on the Lapiplasty 3D Bunion Correction team. So he's actively working to develop new innovations on the Lapiplasty procedure as part of a surgeon team. So we look forward to hearing more from Dr. McAleer here tonight and his patient Laura. So with that, I'm going to turn it over to him.
Thank you so much, Sean, and really thank you very, very much to everyone who is here and attending. I hope you find this this lecture very informative. I'm excited to see what type of questions that you do come up with, and I'm happy to answer all of them for you as best as we can. I just kind of move things along. I want to introduce Laura. She's very special to us. We very much appreciate Laura coming out here today to spend her time with us in the evening, kind of taking her away a little bit from her family. Laura's a great patient. She's a very busy mother. She's one of the physical therapists in our region. She's a very, very active person and enjoys outdoor sports, hiking, camping, running. I think Laura just said that they went on a big camping trip with her family this past weekend, and last time I talked to her, she was rolling up her tent and folding it away and putting it away for the season, because I guess camping season is going to be over now. So Laura had her Lapiplasty procedure performed in November of 2017, and so we're going to be getting ready to approach 2 years now, Laura, right? So how have you been doing since Lapiplasty has, kind of changed things for you?
Hello, guys. Thanks for having me. My Lapiplasty, it's been going well. It's been almost 2 years. It'll be 2 years in November.
Very good. Okay. So we're just going to give you a little bit of quick background on the procedure itself. Just some housekeeping notes. If you take a look on the left-hand side of your screen, these are real people. These are real Lapiplasty patients. You can see Laura's up in the upper left-hand corner. There's a couple of people on the screen here that were some of both my patients and my partner, Dr. William Duke's patients. So Lapiplasty has been FDA cleared since 2015. It's not investigational. It's patented. It's obviously produced by Treese Medical Concepts. And if you are going to be a surgeon that performs this procedure, you need advanced training. Not all surgeons can Lapiplasty, so we're very much involved in the physician education nationwide, and we're constantly trying to show new doctors how to perform this groundbreaking. And I think hopefully here in this lecture you'll see why we think this is really the way to fix bunion deformities. Also, just to make a disclaimer, as with any medical treatment, individual results may vary. There are potential risks in recovery. It does take time. Potential risks can include, but are not limited to, infection, discomfort from the presence of the implant, loosening of the implant, loss of correction or malunion, and if these things occur, additional treatments could potentially be necessary. And tell if the Lapiplasty procedure is going to be right for you. And the Lapiplasty 3D correction procedure is covered by one or more U.S. patents. And if you're interested in learning more about these things, you can go to the align.com website, and there's just a wealth of information there for you to kind of review. So now we're getting to the meat and potatoes of why we're here. So, you know, is bunion pain affecting your quality of life? So I assume by a number of the attendees here, there's either you're either all just bunion buffs and you just are really interested in ankle anatomy, or you probably yourself have a bunion deformity, or you know somebody with plasty procedure is and how it could potentially improve these problems for you. So Laura, how did your bunions, just to kind of get a quick picture of what it was like for you, how did your bunions affect you?
I've had bunions as long as I can remember growing up, and they progressively got worse throughout the years. I really enjoyed going hiking and jogging, and those things were limited to my bunion pain. I'd have to rest because of the burning and the aching. It'd get swollen and red. So I couldn't do all the things that I wanted to do.
Okay. So it was making life a little bit more challenging for you, would you say?
Correct.
Okay.
Mm-hmm.
Okay. All right. I think that's what a lot of the patients are kind of experiencing, and we hear very similar stories from patients who are coming to visit with us. So bunions are also known as hallux valgus. Hallux valgus is the more technical term, but you can use the two terms interchangeably, and both patients and physicians will know what you're talking about. So the big question is, how do you know if you have a bunion? You know, we get asked this question all the time. We get patients that come in with lumps and bumps of all different kinds on their feet, and sometimes they think that their particular bump or lump may be a bunion, when in case it may not be. But bunions are a deformity at the big toe joint. As you can see, the picture on the left is a normal foot, and the picture on the right shows a patient that has an enlargement at the big toe joint. And what we're going to find here as we kind of discuss what this is it's not just an overgrowth of the bone, but it's actually a shift and a change in your normal anatomy. And we're going to kind of get into the details to try to explain to you a little bit better what that means. So bunions are more than just a simple bump. So here on this slide, you can see the picture on the far left is a patient that is a mild deformity. And over time, you can see how patients with more advanced deformities can develop a severe progression that can lead to big toe joint arthritis, crossover deformities of the toes, hammer toes, instability of joints, and pain. So the take-home message here is, if left alone, bunion deformities will progress, and you will ultimately result in a circumstance in which your bunion may not even be correctable through a Lapiplasty procedure, and it could require other things like a big toe joint fusion or other type of additional procedures. So it's always best to identify and proactively treat these deformities so that you can fix the problem right, get it fixed the first time, and then not have to worry about these things again in the future, and obviously don't let them progress to a point where the problem may not be salvageable. So why do bunions hurt, right? Your bunions hurt because the big toe joint is a very complex yet complicated joint. So we have four main bones, a metatarsal bone, a phalanx bone in the toe, and these two lima bean shaped bones called the sesamoids, and we're going to show you some pictures of those. And you also have tendons and ligaments and joint capsule and connective tissue and cartilage and just a myriad of other soft tissue structures that help to make up, bind, and control the motion at the big toe. And so when you're wearing high heels, if you're a gal, or if you are running and you're an athlete, whether you're male or female. If you're wearing certain types of construction boots, and maybe you're up at an angle, you're increasing the weight-bearing forces across that joint space. And sometimes you can have up to 3 to even 6 times normal body weight running through this joint at any given moment, depending upon your activity level. And if these structures are not well aligned, because you've developed a bunion, you're going to cause injury and damage to that joint over time. And that repetitive damage that you're creating is going to lead to arthritis and other significant problems. So what are the symptoms of a bunion? So patients typically know what their symptoms are when they come in. They complain of pain. They'll say the joint gets swollen or red or hot. They'll also describe in some cases electrical or tingling type sensations into their big toe, or climbing up their foot into their ankle and their leg because of irritation of the nerve that runs over the bump. And then in many cases, you can even have some numbness on the inside part of your big toe, and that's a real common complaint. And some of that is because the bone protrudes out, it squeezes on the nerve, and then the shoe sandwiches the nerve against the bone when you're standing and walking for prolonged periods of time. And that is very, very irritated. And in some cases, shoes can have some influence, and not only shoes, but what you do for a living on how you feel with these deformities. So what causes a bunion? So Laura, what do you think? What did you think caused the bunion? What was your understanding before you went through this whole process?
Well, actually, I've seen the bunions on my grandma and my dad, and then I had it, so I knew it was hereditary.
Okay. All right. So you had the cheat sheet. So you knew ahead of time. So you had a little background. Okay. All right. So there is definitely a genetic predisposition to developing bunions. So if you kind of look at your first degree and second degree relatives, and you kind of shake your family tree and you kind of take a look up in a couple of branches, you're probably going to find a family member somewhere that has a bunion that's directly related to you. And this has to do with the genetics of how our joints are shaped, and it also has to do with stability of our foot and a whole bunch of other complicated biomechanics. And so biomechanics sounds like a really fancy term, but really it just has to do with how our joints work and how tendons, ligaments, and soft tissue pulls and moves while we're standing and walking. Other things that can kind of aggravate bunions, again, are certain types of shoe wear. So high heels. So if you're wearing your favorite 4-inch red-soled high heels, or if you're wearing very tight-fitting, improperly fitted shoes, in those cases, it could influence and accelerate the formation of the bunion, and in many cases, it can irritate the presence of the bunion. And also, other things that can kind of have some influence on the progression of your deformity is what you do for a living. So the prima ballerina who suffers for her art and is wearing, terrible shoes on point. I mean, if you've ever seen ballerinas' feet uncovered out of their slippers, you see they develop toe deformities and hammer toes and bunions and calluses and corns and all these different issues. So that person may have a greater influence of her occupation over how she's going to develop that deformity in comparison to maybe someone who's doing an office job, or maybe someone who's an athlete, or someone who wears high heels during the course of the regular day. So we're here in the capital of Missouri, and at our Capitol building, a lot of our female patients that come in to see us, they all wear high heels on these hard marble floors, and they work really hard running across these floors, and it's extremely impressive to see them do so. And these patients that come in, they have a dress code and they wear these shoes, and they wear these shoes for 20, 30 years on a daily basis plus, and that definitely has an influence on the progression of their deformities. And there are some of the culprits: the right foot and the left foot, high heel culprit. So if you can avoid shoes like this, it won't stop the progression of your bunion, but it may help to decrease some of the influence, and it may help to decrease some of the irritation of your bunion. So here's a little break that we can kind of go through just some frequently asked questions and things that we get asked on a regular basis in the office by our patients. So, am I a candidate to have my bunion treated? I'd like to say that pretty much anyone that has a bunion deformity, and I say this very carefully, but anyone that has a bunion deformity could potentially have a 3D Lapiplasty bunion correction, in my opinion, with the exception of certain individuals. So if you've allowed your bunion to progress over time and you ultimately have developed osteoarthritis of your big toe joint that's progressed significantly, you may not be a great candidate for the procedure, and we may need to address the deformity at the big toe joint, which potentially you do better with a fusion at that level. And we're going to kind of talk about that a little bit as well. And maybe certain patients that have certain types of diseases, or if the patient's health is not great, there's certain factors to be taken into consideration there. But really, that's the time when you sit down with your doctor, they evaluate you appropriately, they look at your X-rays, they look at your medical history, they look at your medication list, and you guys sit down and really kind of hone in on what your goals are, and you hone in on your overall health, and you make a good decision if you should have the procedure. Age limits. Are there age limits on this procedure? Well, if you're 12 years old plus and you have closed growth plates, you can have this procedure. In our practice, we have teenagers that come in with bunions, and we don't fix the bunions at that age because we're just really excited about Lapiplasty. We fix them because the patients come in at a very young age with severe bunions complaining of pain. And so this again shows you that this is a genetic predisposition for this problem, because when you have a 15-year-old coming into your office who's an ice skater, who is an athlete trying to wear cleats on the field, and they're having significant pain and discomfort because of this deformity of their foot, it's not because they've been wearing high heels for the last 20 years. It's because they have just instability of their foot, which has led to the deformity. And we have patients in our practice up to the age of 80 years old. We have a patient that comes to mind, very physiologically young, that we fixed her bunion about 6 months ago, and she's doing phenomenally well. No arthritis, great motion of her joint, and she's back at it with her friends and family. And so again, if the bunion is so severe, can it not be treated? Well, we can treat severe bunions, but we like to be careful if you have big toe joint arthritis. So that's just something always to be taken into consideration. And if you've had bunion surgery in the past, can you have Lapiplasty? Yes. We perform lots of repeat revisional bunion correction procedures when patients come in to see us and have had previous failed traditional type procedures where the bunion was undercorrected. This technique is very powerful, and we're very, very excited to provide this service to the patients that have had failed bunion surgery, just because it really just makes such a big difference in their life, and they get back to doing the things that they want to do comfortably. So main key thought, bunions are progressive. They don't go away. They're not going to go away on their own, and really there's very little you can do from the outside to influence them to keep them from progressing over time. And that's an important take-home message. So what happens if I don't treat my bunion? Well, this slide shows a patient, and if you look on the picture on the right, you may be oohing and eyeing right now because that's a pretty dramatic deformity, but this is one of my patients. So this is one of my patients who is in her 50s. I treated her at my practice, and we corrected her bunion and straightened her toes and did a little bit of work for her. And her goal is to be able to walk her son down the aisle at his wedding approximately 4 to 5 months after her surgery was completed. She wasn't able to wear shoes because her deformity was so bad. And this is what happened to her when her bunion deformity was allowed to get out of control over time. So bunions get worse. It can cause arthritis, crossover toes, hammer toes, the development of bone spurs, which is also a form of arthritis, as well as just generalized pain through the ball of the foot. I have patients regularly that come in to see me and they say, well, I have a bunion, but my bunion doesn't hurt, but the ball of my foot behind my toes hurts. And that's because the foot is unstable and there's excessive weight being pushed through the ball of the foot when patients walk, which causes destabilization of the toes and can lead to these other deformities. So my answer always is, your foot is out of proportion, it's not stable, we fix the bunion, we fix the rest of the pain. So in many cases early on, your pain can be managed with things like pills and shots and, maybe pads and braces. I don't know who would want to wear these 2 braces. I don't think I could even. Laura, would you wear these?
No, absolutely not.
Laura, if I go to your house and I open up one of your drawers, am I going to find these in there?
Absolutely not.
Okay. All right. So I don't know who can fit these in their shoes. I see these things on the market. You could spend a pretty penny on these, but unfortunately, things like this, these conservative type bunion splints and braces of all different kinds just really are not going to solve the problem. It is a mechanical instability in your foot. And with these types of things, I think really what you end up hurting is your pocketbook, and you don't get any significant benefit. So conservative treatments are really designed to keep you comfortable, but it's not going to solve the problem. So toe spacers, silicone pads, splints, stretching, inserts, orthotics, all these different things can be used. However, it does not fix the problem, and you're really kind of strapping your foot up and almost kind of applying external scaffolds, trying to hold the foot in position, and unfortunately, these things do fail over time. So let's talk a little bit about the anatomy of what a bunion is. So there's again, like I said before, there's a misconception that a bunion is just simply a bump, because that's what you see. You see a bump on the outside of your foot, and people have been told forever, well, the bone is just kind of overgrown, or there's like a misshape of the bone, and the bone itself where the rubbing is occurring is abnormal, when that's not the case. The bunion is not just a bump. It's actually a malalignment or a misalignment of the joint. So if you look at this, you can see the outline of the toe and the big toenail, and you can see there's 2 bones in the big toe, and those are the proximal and distal phalanx bones. Don't worry, there's not going to be a test after this on the anatomy, but just to kind of give you some idea on what we're looking at. And you see the metatarsal bone, which is that longer bone behind those 2 toe bones. And there are these 2 lima bean shaped bones at the bottom of the joint, and those are called the sesamoid bones. And that is the complex that makes up the inside of the foot, the structures that lead to the deformity. And there's instability at this joint called the tarsal metatarsal joint. And that's the arrow on the bottom of your screen pointing to that joint there. And that's between a bone called the metatarsal and the cuneiform. And that instability allows for alteration in tendon pull and soft tissue alignment, which ultimately can lead to the big toe drifting, the metatarsal bone protruding on the inside of the foot, leading to the presence and appearance of a quote-unquote bump. And that's where the nerve gets impinged, that's where the soft tissue gets stretched, and that's where your pain begins. So we can't just simply shave this off, because this is like an unstable Jenga tower, and traditional methods of just kind of cutting and shaving and moving does not work here. So the joint gets addressed, we put the metatarsal back into position, and that seems to be a much more logical approach than some of the traditional methods that have been out there. So here's some X-rays for you guys to review. So on the left, you can see what a normal foot looks like. So again, you have the 2 bones in the big toe. Those are the proximal and distal phalanx bones. Then you have the longer bone called the metatarsal bone. You have the 2 little sesamoid bones, like the little lima bean shaped bones. And then you have that joint in the middle of the foot called the tarsal. And you compare it to the X-ray on the right, you can see how the metatarsal bone is straight, but it's protruding. The base is unstable, which is leading to the metatarsal bone leading towards the midline of the body, and the big toe joint is drifted. The sesamoids are out of position. The whole Jenga tower, again, is tipping over, and you're developing this deformity. So you can see all that going on right there. So 87% are misaligned in 3 dimensions. And you may say, well, what does that mean and why is that important? Well, when you have one of these deformities, the bone doesn't overgrow, like I said before. You have a shifting of the metatarsal towards the midline of the body. It elevates and it also rotates. And we're going to kind of show you what that means. But if you don't correct for those 3 planes of deformity at the time of your bunion correction, you're doomed to reoccurrence. So I really like this slide. You who know your geography and know Italy. So this is a representation of the Leaning Tower of Pisa. So beautiful structure, gorgeous architecture. Unfortunately, it just wasn't quite set right in the ground. So you can see how the Leaning Tower of Pisa is kind of tipping over to the side, just kind of above the picture of my head here. And you can see how the metatarsal bone kind of does the same thing. It has an unstable foundation, which allows for a drift or a lean of the metatarsal bone away from the rest of the foot towards the middle of the body, kind of allowing for that protrusion of the bone to occur. And that's one of the dimensions of the deformity. Here we have the second, where the metatarsal bone actually elevates up in the air. So I like you to think about going to your favorite local restaurant, you sit down with your family and you put your drink order in, and the waitress brings over your soda or your water or what have you, and she puts it on the table, and you reach over and your arm rests on the table, you grab your glass, and all of a sudden the table is tipping back and forth and sloshing, the drinks around and everything's moving, and that's because the table legs are all uneven. And you're under there with your kids and you're putting sugar packets and you're putting napkins underneath the leg of the table trying to stabilize this thing so you don't get drinks and your meal all over the place. So that's kind of what happens with the foot too. But the foot has 3 points of contact: the heel, the first metatarsal, which is the one we're talking about where the bunion is, and the fifth metatarsal where the pinky toe is. And so that's like a tripod. And so think about if you had that tripod and one of the legs was kind of collapsed and elevated, how your foot would tip over. And that's exactly what's happening here when you have a bunion deformity. So you may notice that your foot flattens out a little bit and the bone elevates as it shifts over as well. So that's the second plane of deformity. And then my very favorite of all of them, the third plane of deformity, which is how the metatarsal bone rotates in something called the frontal plane. And I always like to use this analogy of car wheels or car tires on the pavement. So if you have tires and they're contacting the pavement and your alignment of your car is off because you hit a good old pothole and the tire is kind of riding out on the edge, you start to bald that tire prematurely. Well, that tire is not going to last as long as you want it to. And your joint of your big toe joint is like that as well. So if that metatarsal bone is shifted, elevated, and rotated, your joint is not tracking properly, and you start to wear down and destroy your cartilage prematurely, which can lead to big toe joint arthritis, pain, and other problems long term. And the longer you leave it like that, the more permanent the change. So unfortunately, tires are very easy to change out, and you can get a new set of tires, even if it may be pricey, but your big toe joint is not as easy to swap out. So it's always best not to let the wear and tear take effect before you do something about the problem. So let's talk about traditional procedures and why these things, unfortunately, are wrought with complications and why they can fail as reflected in the literature. So this is an example of a traditional two-dimensional cut and shift type osteotomy, or a bone cut. That's what osteotomy means. You can see here that the bone is somewhat misshapen. The sesamoid, that round lima bean shaped bone on the outside of the foot is not really well positioned. The anatomy looks off. The toe doesn't look perfectly straight. You can see we've kind of taken a straight bone and we've created a banana shaped bone, which is abnormal, and we haven't really addressed the source of the patient's problem. So that would be like me taking the Leaning Tower of Pisa and go, hey guys, let's fix this structure. The way we're going to do it is we're going to shave the side of the tower off, and then we're going to cut it up at the top and push it, and then we'll screw it back together because kind of relatively it's straight. Now, I don't know about you. Now, I haven't gotten a chance to see this in person yet, but I don't want to go and see it after they do this to it. Okay. So if you look at the anatomic image on your right-hand side, you can see we've taken a straight bone and we've made it abnormal. It's out of position. It's out of shape, and the joint is still unstable. So it would be like us doing this to the Leaning Tower of Pisa, and the foundation is still unstable. It is not straight up and down. We always use the analogy of if your mailman came to your house and by accident he backed his mail truck up into your mail post, you wouldn't cut the mail post, shift it over, and put screws into it to reposition it. You dig up the bottom of the post, you'd realign it, you'd put concrete down there, and then you'd put your dirt and get your flowers going and your grass and everything else. You'd realign it at the base, at the ground, at the foundation. And so that's how we want to fix these problems, not like this. Because if you leave this joint unstable, these things are going to reoccur. So you can see here, we've made a straight bone, we've made it crooked, and you can see what the X-ray looks like, and you can see that we have not yet addressed the area of instability. So these look okay from the outside though initially. You know, when you get off the operating table and you heal, you say, well, my doctor did a good job because clinically my toe looks straight. I feel pretty good about it. But we like to say that leaving this unstable joint like this and not really truly correcting this problem in 3 planes is like putting lipstick on a pig. And that's really what you can these types of procedures to. So here's a little data for you. If you do these problems correctly, there's a 12-time reoccurrence if the 3-dimensional nature of the problem is not addressed. 12 times. That is a real number. This is through published studies that you can see the references on the bottom of the page here. And also, 1 in 3 patients are dissatisfied after 2-dimensional bunion surgery. And this is not my opinion. This, again, is reflected in the literature looking at large patient populations. And also, there's an up to 70% chance of reoccurrence over time when performing traditional procedures. So these are not good numbers. In the old days when patients would come into my office if they had a bunion, like if Laura came in, right, Laura? So Laura, you had bunions for a long time.
Correct.
Right. So you knew about bunion surgery before you knew about Lapiplasty.
I did.
Right. So when you heard about traditional procedures and you working as a physical therapist, seeing patients having these things, what was your feeling on having the procedure done?
I just wasn't real confident in the results and just wasn't ready to make that commitment. I wanted to know more and see what other options were out there.
Right. So, and that's our feeling too, is that in the old days, I used to say, if you came in with a bunion deformity, I'd say, no, wait as long as you can because bunions come back. Now when patients come in, regardless of their age, I say, no, fix the bunion as quickly as possible so that we can avoid permanent joint damage and deformity over time. So now we're going to talk a little bit about Lapiplasty. And we're going to talk about why we like this better. You know, we feel that when you're going to fix your bunion, you want to fix your bunion right the first time. This way you can move along with your life and you don't have to reflect back on this in the future. You can just forget that you even had anything done. So here's an example of a Lapiplasty procedure. So a couple of things just to note. The joint is alignment, the sesamoids are back, the metatarsal is straight. Yeah, we have plates and screws in there, which, you know, you kind of have to do some work to get the job done. But if I covered up that plate and screws, you'd look at that joint and say, that's a normal foot. If you didn't know the hardware was there, you wouldn't see any change in that big toe joint. You'd say, well, that patient does not have a bunion. And so how do we do this? So we have specialized patented instruments that allow for us to reduce your deformity regardless of the severity of the deformity. So I can fix a mild, a moderate, or a severe bunion with this method by in the correction, realigning the bone, and then stabilizing that bone and getting that toe small refined plates and screws in order to maintain position at that we fuse at the first tarsal metatarsal joint. And this allows for us to perform your correction and allow for you to continue to perform activities, stand, and carry out the things that you want to do. And so, Laura, after having your bunion procedure, are to exercise and running?
I am back to exercising and running. I am running 3.5 miles a couple times a week, and it feels good to be back on my.
Awesome, really good. That's what we like to hear. So again, here's a before picture on the left of direction. So you can see here how the metatarsal is out of position on the left and it's been restored on the left. You can see how the sesamoid bones, those lima bean shaped bones, are shifted and moved out of position on the left underneath the metatarsal head where they're supposed to be on the right. And you can also see how the joint itself, the big toe, where it kind of meets the toe, it's back, aligned, and congruous or even. Comparison to on the left where part of the joint is kind of protruding and hanging out and poking against the skin. And now let's compare a traditional osteotomy, that two-dimensional shift approach in comparison to the picture on the right. So Lapiplasty is on the right with restoration of anatomy, and on the left, this kind of weird shaped banana shaped bone. The joint is not quite squared up. Going to lead to some osteoarthritis over time, and you have that sesamoid bone kind of hanging out there in the middle. The space between that first metatarsal and tarsal is pretty wide still, and the base at the foundation is still not yet been addressed. And then let's talk about minimally invasive surgery, because this is all the rage right now. So Laura, if you look at these two X-rays, the X-ray on the right, which is Lapiplasty, on the left, which is minimally invasive two-dimensional surgery, what do you see here? Like if you're coming in to have bunion surgery, and I showed you these two X-rays, what would you think about these two?
Don't like how the one on the left is still kind of rotated out. It looks like the hardware looks scary in that one too. Where the bunion was, it looks like the bone is kind of broken. The one on the right, the Lapiplasty, it looks even. It looks like it's in normal alignment, and it looks like it's going to be more comfortable.
Yeah. So if this was a broken bone, if this was a fracture, if a patient came in with a fracture, position, the picture on the left would be completely unacceptable position. We would never say that this doctor did a very good job. Well, what went wrong here? Why is the head of the bone cut and shifted and kind of teetering on a little here with this big long pin and screw? I mean, this kind of looks a mess and scary, because I do worry about the long-term repercussions of these types of procedures and risk for reoccurrence. And how are we as Lapiplasty surgeons going to correct these later? Start to fail. But the X-ray on the right shows restoration of anatomy, and the X-ray on the left shows severe deviation in anatomy to the point where it's concerning in my mind. So this is what, and a lot of doctors are doing it, but it's a very, very old technique that goes way back to like the 1950s, and they failed then. And unfortunately, a lot of doctors forgot about some of the complications that could occur with that, and now we're seeing those procedures kind of make a resurgence again. So this is a procedure I would not want a family member to have, or one of my patients. Now this is an example of a Lapiplasty again on the right, and this is a traditional Lapidus on the left. So some of you may have heard of a Lapidus procedure, and that is also a fusion of the first tarsal metatarsal joint. The original Lapidus procedure was described in 1951 by a doctor named Paul Lapidus, and with this procedure, they didn't really fully address 3 planes. This still is a dimensional correction. As you can see, the metatarsal has not yet been fully corrected. It's kind of a eyeball technique where it's not reproducible. You're not using specialized instrumentation and equipment to get the back into position, and you're not using precise instrumentation to cut the bone to position and realign it. So that's why, unfortunately, also traditional Lapidus can fail, and you can there. And then finally, we show you a normal foot and a patient that's had Lapiplasty. And again, I would argue that if I covered the X-ray on the right and I hid the hardware from you, you'd have a difficult time determining which patient had surgery, and you'd have a difficult time telling me which patient had a bunion originally, because in essence, the X-ray on the right has allowed for restoration of alignment. And another big question we get asked is, does my big toe joint get stiff after this procedure? And the answer is the joint is free to move. The joint that we're going to stiffen is this first tarsal metatarsal joint. And believe it or not, the instability at that joint and the movement at that joint is what allowed for the deformity to come on in the first place. That joint should not move to the degree that it currently does. And by fusing that joint, you stabilize the foot, you stabilize the arch, and your big toe joint will be free to move properly, and you can almost eliminate the risk to have a reoccurrence there. And we're going to go over some literature here that's going to show that to you as well. So Lapiplasty fixes the root cause. It's a three-dimensional correction. We're going to get you back on your feet quickly. You know, each surgeon's a little bit different as far as their weight-bearing protocol, but we're going to talk about mine. And also there's minimal time off of work, just kind of depends upon what you do for a living, that too. And it's going to allow us to permanently secure that unstable joint in your foot. Plasty has 10 published clinical articles, which you can research online. And you can, if you have access to a medical library, you're going to read all of these. And it shows that in these studies that there's a 97% success maintaining the three-dimensional correction over a 13-month period in one of these most recent publications. Here are some before and afters. I'm really proud that these before and afters are real patients. These are my patients. So you can see the patient and the picture on the left. They're pre-op, and then on the right, they're 12-week post-op. You can see their incision placement on top of their foot. You can see the reduction of the deformity. You can see the derotation of their toe, and you can see cosmetically how they're very, very happy with the reduction. And I actually got a hug. I think I got a kiss on the cheek for this one too. Here's another one of our patients also who underwent and you can see here also a dramatic difference in reduction of the deformity, and this is 12 weeks out, and this patient was walking back in their shoes at that point. And then finally, we also have one additional example for you, another one of my patients, and you can see again a very prominent large eminence on the inside of the foot, that big bump next to that big toe joint, causing lots of pain, lots of neuritis or tingling and burning into their digit, difficulty walking, difficulty wearing shoes, inability to run and keep up with their family members. And you can see now restoration of alignment with complete reduction of the deformity and back to full activity, and very, very happy to do so at 16 weeks. So we want to get you back to your activities. We want you to enjoy, and that's the whole point of the procedure. So we're going to talk a little bit about what the recovery looks like for you and why we can kind of get you moving quickly. So one of the main things patients ask is, when can I walk after the surgery? And in our practice, we let all of our patients walk the day of surgery in a protective cast boot for 6 weeks, and then at 6 weeks we transition them into their tennis shoes. And so the reason we can do that is because the way that the plates are configured, this 2-plate 8-screw construct allows for appropriate stability in multiple planes, which allow for relative stability and a little bit of micromotion at that joint, which helps to stimulate healing, and it helps to maintain correction so you can be up on this foot. So 2 plates in this case is better than 1. And this is what we're looking to do for all our patients. And we allow all our patients in our practice, and in my experience, we allow all of our patients to walk regardless of weight and age following these procedures. Days, here's your cast boot. Sometimes we lovingly refer to this as a moon boot. And then we have you walk in that boot for about 4 to 6 weeks, depending upon surgeon protocol. At the 6 to 8 week mark, you're back into your tennis shoes and high impact activities at anywhere from 4 to 6 months. So Laura, because you're a runner, when did you get back to running and exercising? What point in your recovery?
In my experience, I was able to start back with some light running at about 4 months, and then I was able to gradually increase my distance and time with that.
If I remember right, like at 4 months, did you run a 5K like almost immediately when you did this?
I ran 2 5Ks
Okay.
shortly after that 4-month mark.
Okay. Now that may not be typical for everybody. Laura very active ahead of time, and she wanted to get back at it, but yes, she did. She ran 2 5Ks back to back, and I was a little nervous, but she did wonderfully, and she continues to do so. So let's kind of go over a little bit of my protocol here. And this is kind of what I like to. This is a little synopsis of what I give my patients. I kind of make them a little handout and a packet. And this is some of the information that we provide them. So immediately after surgery, after you come out of recovery, after your correction, we give you some pain medication, some little bit of narcotics, so just try to keep you comfortable. We make sure that anytime you're standing and walking on that foot, we always have you wearing your cast boot, that black moon boot that you see up in the right-hand corner. We have you keep your dressings on. We have them clean, dry, and intact, and we leave them there for the first 5 days. We encourage lots of rest, ice, and elevation, kind of toes above the nose idea where your foot's really elevated to keep the swelling down. We like to give you aspirin to reduce the risk for any type of blood clot issues or things like that, which can happen with extremity surgery. So we're always very cautious to avoid those problems, and we use aspirin and other little pumping devices and things like that. We give you ankle range of motion exercises to perform. And so that's pretty much the initial protocol. So Laura, when you came out of the operating room, how did you feel? Do you remember at all?
I don't really remember feeling much pain initially. I think it was probably numb. But then, you know, as the time went on, the first day or two, I did walk with crutches in my boot because I was a little scared to put weight on it. And it was, you know, a little painful there at first. But after like the first 2 days, I started walking on it in the boot. And I took my pain medication, you know, to help.
And did it help cut your discomfort when you had that?
Yes, it helped quite a bit, actually.
So also, what kind of things were you doing initially after surgery also? Like, you know, just kind of when you were home for the first 5 days?
I was resting with my feet elevated, watching Netflix.
Okay, all right, fair enough.
But I stayed home from work for the first 2 weeks, and within those 2 weeks, I started getting to be more active in my boot. I went and got a facial done with my mother-in-law and went out to lunch. So I wasn't just tied down to my couch the whole time.
Okay. Were you able to kind of go to the kitchen, get snacks, use the restroom comfortably? I mean, were you able to do kind of like just basic things during the first couple of days too?
Oh, absolutely. I was able to, you know, get up and use the restroom and, you know, do whatever I needed to do. Nobody needed to stay there and wait on me hand and foot. I was able to take care of myself. Okay,
that's good to know. And that's what we find in general is the typical kind of experience for the patients. So postoperative visit, we kind of lovingly call this the big reveal because we take all your dressings down, we let you take a look at your foot. And so this way you can kind of, for the very first time, see your correction. You know, but sometimes these things can be a little scary to look at, you know, if you're not used to having surgery or if you haven't had surgery before, you know, you can have a little bit of bruising, maybe some swelling. You know, you're going to see your incision sites, and you know, everything's in the infancy of healing. And we usually encourage continued rest, ice, elevation, limitation and activity, continued use of the boot. And we also want you to begin washing your foot. So we usually let patients start taking showers at this point with running water. We discourage any type of soaking of the foot or application of ointments, creams, or anything like that to your incisions. We let it kind of stay dry when you're not in the shower. And we let you start doing some big toe joint range of motion, some ankle joint range of motion exercises. So when you started doing your range of motion exercises, Laura, after surgery, how did that, so you're a physical therapist, right? So you're constantly kind of, you know, pushing patients, no pain, no gain, let's get you better, let's. Was that for you having to work those exercises yourself?
It was definitely an eye-opener for me to know just how far I could really push that toe joint to get it moving, and the experience I was able to do that with other patients that were going through the Lapiplasty recovery. you got to stay on top of your exercise, push through that range of motion if you want to gain it back. So
I think that's really good advice. So usually what happens is we see about the 2.5 to 3 week mark at our practice, and that's when we take stitches out. Now I use a running subcuticular stitch, which means I run stitch underneath the skin, so remove, and I use an absorbable stitch. Some docs may choose to use different types of sutures or stitches, just depending upon their experience and what they like to close with. But you could have a little bit of swelling and some tingling and maybe a little bit of discomfort still, but you'll be walking in your boot. We encourage you to do so. We don't want you doing any high impact activities, but we do kind of want you to do the basics for yourself. Again, continue with the rest, ice, anti-inflammatories, aspirin, and again, continued showering, bathing, and doing your big toe joint range of motion exercises. But this is kind of the point where patients start feeling like themselves again, where they kind of get over that initial hump of having the procedure done, and they start kind of doing the things that they feel comfortable doing. So how did you feel, would you say, at this kind of 3 week mark?
At the 3 week mark, I was back at work on my feet in the boot. And I was feeling, I don't think I was taking any more of my ibuprofen at that time, but I would come home from work and elevate my foot a little bit and ice it.
Were you getting swollen towards the end of your day after having the procedure?
I did have some swelling towards the end of the day, but like you said, I'm on my feet all day with my job. So I wore a compression stocking to work and would go home and elevate. And then it would go down, and the next morning it looked great.
Yeah, that's a really good point, because that's one question that patients ask a lot is, what is it going to look like, and why do I have swelling? And I tell patients regularly, you may have swelling for 6 months, on again and off again, maybe even up to a year, a little bit here and there, depending upon your activity level. And everyone gets concerned with the swelling, but it's pretty normal when you have surgery on your foot and gravity is kind of pulling all that swelling down there, and if you're up on your feet a lot. So you're able to get back to work at 3 weeks. That's really great, especially since you're dealing with patients as a physical therapist. The 6 weeks, we call this early graduation. So this is the point where we transition you out of your boot and back into your walking shoes. But just because you're back in your walking shoes doesn't mean you're completely free at this point. So again, we tell patients no high impacts, no plyometrics, no jumping, no running, no stair climbing for exercise, no elliptical machines, no, if you're a weightlifter, no deadlifts, calf raises, things like that. We do allow for a little bit of light exercise, such as maybe using a bike or a rowing machine on a low setting. Or we may let you do some light upper body weights with a weight stack pin-based cable pulling machine if you're in a seated position. Just kind of varies from doctor to doctor, but these are some of the things that we allow at our practice. If you're driving and this is your right foot that you had surgery on, you can't drive for 6 weeks. And then at this 6 week mark is when you can put your foot and use that to brake and to push the gas pedal. And it's really not so much the go, it's the stopping. If you had to stop an emergency, if you had to put a lot of pressure on that foot, you may not be able to effectively do so, and it could be dangerous for you. So we try to avoid any driving. And then at the 12 weeks, we call this graduation day part 2. We allow for some increased activity. We let you wear any kind of shoes you want. In many cases, we make our patients orthotics to wear, just to kind of give them a little extra support as they continue to heal through this process, and they wear those in their shoes. And you can swim, soak the foot, because all your incisions should be healed at this time. But we still like you to rest, ice, elevate when possible, and kind of take it easy. And at this point, we don't release you to sport. So I know you were itching to get back to running at this point, Laura, and we kind of had to tell you no.
Yes, I had to wait a little bit longer, but it was worth it.
It was worth it. Okay. And then at the four-month period, that's when you ran your 2 back-to-back 5Ks.
I did.
Okay. And so this is when we release you. This is, are you done with me yet? When the patients are saying, get me out of here. I'm finished with this. I don't want to do this anymore. This is when you can start walking barefoot. we release you from all restrictions. You can return to full high impact activity. But we do still recommend that you use compression socks from time to time when you're going to be up on your feet for long periods of time, because that can help with any residual swelling. And then also we do follow up with you long term, so maybe 6-month mark or the 12-month mark as time goes on. So a couple more FAQs. So one, can I return to work? Well, in Laura's case, she was able to get back to work at 3 weeks because she had some ability to do so, and her work kind of worked with her to allow for that to happen, and they limited her activity to a degree. But if you're a laborer and you're doing heavy physical duty, well, then you can't maybe return to work until 12 weeks if you're lifting, carrying, pushing, pulling. But if you're doing desk work, you know, it could be 5 days, 2 weeks, maybe 3 weeks, depending upon how you're feeling. If you're a nurse or you're a teacher, you know, maybe it's going to be more 3 weeks or 6 weeks. It just kind of varies based upon you and your occupation and how much physicality there is to that job. And you're able to drive after 6 weeks with your right foot. If it's your left foot, as long as you're not taking your pain medication, we do let you take some short trips. So we don't want you taking a cross-country trip, but maybe a trip to the grocery store or a trip to work or something like that would be okay. And this is a question we get asked a lot. Can we have both feet done at once? And I usually try to dissuade patients from having both done at once. I prefer to stagger them. The soonest I typically will do it is 6 weeks apart, because I want you to have one good foot to stand on that's in a shoe to avoid injury, and I'd hate for you to have to walk around in 2 boots. So we've heard a lot from Laura. So this is Laura, and this is Laura running on the trail here, looking very good after her Lapiplasty has been performed. So Laura, is there anything else as a patient that you is just important, or something that you thought of that you said, oh, I wish I knew that, you know, in having this procedure?
So mine was performed on my right foot, and I didn't even think about not being able to drive the first 6 weeks. I have 4 kids that I've got to run around to school and practices, plus my job. And so that was a little shocking at first, but I made arrangements and it worked out. The main thing that I tell people is to really work that range of motion of that big toe. Just really keep pushing it. You're going to push it, you know, as far as you can tolerate to get that joint moving.
And so Laura, that picture up in the right-hand corner, that's you working.
Correct.
At the physical therapy department, and who's with you on the left?
That is another Lapiplasty patient of mine. We got her up and moving. She was pretty active and on her feet as well.
All right, so you had like a unique perspective as being a patient, but then also getting a chance to be a therapist treating a patient that had it.
Yeah.
So Laura's a phenomenal resource for us as a local therapist, and we love referring patients over to see her because of what she's experienced. Getting ready to, when she can't run outside, she's running on her treadmill. So you're back to full mileage now, no pain, joint is functioning properly, no reoccurrence. So you have had it?
Since I've had it, I've had no issues with that foot. The bunion, I have no bunion pain anymore. I've got full range of motion in that big toe. Now my left foot, I have a bunion on that, and I feel it from time to time.
Well, I think Lapiplasty is there. You need it. So are you able to wear whatever kind of shoes that you want comfortable with that right foot?
Yeah, I'm able to wear whatever shoe I want to wear. Before the surgery, I was not about to wear any high heels because the main reason it was painful, but I'm also clumsy. You still won't see me in them. But if I were to wear them, I don't think I'd have the pain that I did before. The shoes, my tennis shoes, I was blowing out the sides of them prior to surgery because the bunion was putting holes in the sides of my shoes. I haven't had that issue in the past almost 2 years now. Same pair of shoes and no holes.
Very good. All right. So it's a little bit less expensive for you when you go. This is a reminder, as with any medical treatment, Individual results may vary. There are potential risks in recovery. Potential risks can include, but are not limited to, infection, discomfort from the presence of the implants, loosening of the implant, and loss of correction with non-union or malunion. And if these occur, additional treatments could potentially be needed. Okay, and if anyone's interested in learning a little bit more about Lapiplasty and where they can find a surgeon that performs Lapiplasty in their area, or if you want to come on out to visit us in Jefferson City and meet me, and you can meet Laura, you can go to alignmytoe.com/doctor, and we have a physician finder on there, and it lists all the surgeons across the United States that perform these procedures and their level of expertise and the number of procedures that they've performed nationwide. And so I think this is where we ask questions. Sean, do you have anything that we should cover?
Yeah, absolutely. Yeah, thank you, Dr. McAleer and Laura. That was great. Great to hear your experience with the procedure from both sides of it. We actually do have a lot of questions, so I encourage everyone to stick on. And if you have some questions that you still want to ask, feel free to type them, and we'll get to them as we go here. So I guess I'll kind of start at the top here. One of the first questions we got was a patient with Morton's neuroma, and they're wondering, can the bunion cause their Morton's neuroma?
So we see this very commonly, that because of the lack of proper weight bearing at the joint that has the bunion, patients get more pressure on the other metatarsal bones across the ball of the foot, and that can cause an impingement of the nerve, and over time that mechanical trauma can cause neuromas to form over time. So I see patients quite frequently that have not only bunions, but they have neuromas as well, and both problems can be addressed at the same time.
All right, great. Thank you, Dr. McAleer. A related question, a patient with knee pain and knee issues. Do you see this in your practice, that the bunions can be causing other issues kind of further up the chain in their knee and other joints?
Yeah, absolutely. So again, if your foundation is off and your foot is misaligned and the foot kind of tips a little bit and the arch collapses to a degree, it creates a stretching of the interior of the knee and a compression of the outside of the knee, and the knee will actually track differently. So your feet are your foundation. If you have bunions and you're kind of flat-footed on top of it, that will definitely affect your knee alignment, and it can go all the way up to your hip and your back and your shoulders and the rest of it.
All right, great, that makes sense. A related question, so patients with hammer toes, can you talk about how common they are with bunions? Can you fix them in the same surgery? And is the recovery time longer if you do hammer toe correction at the same time?
So yes, you can perform hammer toe correction at the same time as a Lapiplasty correction. It just adds a little bit of time to the procedure. Recovery remains the same, because typically you'll recover from a hammer toe more quickly, and the protocol for hammer toe surgery typically afterwards is less stringent than the Lapiplasty protocol. So you'll still be back in, you'll be in a boot walking for 6 weeks, and then back in your shoes at 6 weeks. But if you do have hammer toe surgery at the same time, which is typically recommended that you get it all done together at once, so you don't have to come back and do more surgery later, you may just experience some additional discomfort or swelling, and it may take a little while longer for you to kind of perceive yourself as getting back to normal. But we do encourage those procedures to be performed together at the same time, because the root causes of why you develop the bunion is similar also for the hammer toes. There's instability and changes in mechanics and pull of the tendon. They go hand in hand.
All right, thank you. So I guess maybe a related question to the question about the knee pain. Someone typing in a follow-up question. If your patients have knee arthritis and need a knee replacement, is there a certain order that you recommend first? They get the bunion done first or the knee replacement done first?
Yeah, I usually recommend, and this is not just because I perform Lapiplasty procedures, but I usually recommend to the patients that they have their foot corrected first, because that's their foundation. It's going to change the angulation of how their tibia interacts with their femur, which is at the knee. And so if you fix your foot first, then your orthopedist has a better understanding of what your needs are at your knee, I think. And we have an orthopedic department at our group, and we work with our ortho doctors regularly, and we have these discussions regarding these patients with these problems.
All right, thank you. A couple of questions about the actual surgical procedure.
Sure.
I'll just kind of start at the first one related to it. Is it do patients typically stay overnight, or is it a day surgery, or what's the most common in your hands?
All of our patients go home the day of surgery. Thus, like I said, about 250 procedures performed at our group. Not yet had one patient that required any type of hospital stay. We typically do these in an outpatient surgical center with a full anesthesia team and nursing complement. So the procedure takes approximately 60 minutes, give or take, depending upon the individual needs, and the patients go home after they recover in the recovery room.
Great. Can you talk about the anesthesia that's typically used? A couple of questions about what type of anesthesia are they put under? What's that experience?
This is a general anesthesia, this procedure. Based upon the duration of time, we typically do use a tourniquet, which is very common with extremity surgery. And a tourniquet is like an inflatable blood pressure cuff that gets inflated and it's left up, and that helps to reduce bleeding during the procedure, and it allows for us to work faster and visualize the structures better. The downside to the tourniquet, it's very uncomfortable to have that on if you were awake. So patients don't tolerate that. So we always put the patients to sleep. All of them go to sleep for the procedure. We do a full general anesthesia with an anesthesiologist.
Perfect, thank you. Maybe a question about switching gears here a little bit, but there's actually a couple people that ask this question of, they have bunion, and some of them are forcing, other issues like you talked about, like second hammer toe, but their bunion itself is not very painful. How do you typically counsel patients when they come in with that type of condition?
Yeah, so that's a really good question, because this also, we see this frequently where patients will come in and they'll say, the ball of my foot hurts, or I have hammer toes, very painful. I have a bad bunion, but it doesn't hurt. What should I do? So the problem is the foot, you can't treat each individual deformity as an isolated deformity, because everything has to line up and fit. It's like a jigsaw puzzle. So if you have a very bad crooked crossover or hammer toe, and you want us to straighten that hammer toe and just address that, but your big toe is kind of moved over and tucked underneath the second digit, well, I cannot effectively correct that deformity without going after the bunion as well. Or if you're having pain across the ball of the foot, or if you have a neuroma, or you have some other type of pathology, in order to balance the foot and realign everything, you really do kind of need, in most cases, to address all the deformities at once, which would provide you with the best long-term result. Because if you leave it be, the rate of reoccurrence of these other problems is high. So it's best to kind of look at the patient as a whole, see what their needs are, and kind of work with them to kind of make them understand the best plan possible and the pitfalls of not kind of correcting the deformities as needed. So
great. Related question to that is, patient in particular had what they refer to as their toes are all kind of tilting outward along with the bunion. If they get the Lapiplasty procedure done, will their toes straighten out?
No, they will not. So sometimes patients can develop a problem with their metatarsal bones where they're all deviated or pointed towards the midline of the body. We call that metatarsus adductus. And in those cases, a lot of times all the toes are swept out away from the body, and they're kind of facing the opposite direction. So whoever you work with that's working you up for these problems, they have to take the appropriate X-rays, look at multiple views, really truly identify the reason why all of your toes are deviated, and address it accordingly. Because if you fix the bunion by itself in an isolated fashion, you'll have a large gap between your first and second toes in a lot of cases. And in some cases, with certain types of foot deformities, not to get too much in the weeds here, but if you try to correct the bunion and you leave some of these other deformities alone, it can be challenging to really fully reduce the bunion even with this technique. So you have to address everything, again, along with the bunion, kind of like, again, that jigsaw puzzle kind of puzzle piece idea where everything has to find its place and be put back appropriately to make the picture whole.
Yeah, excellent. Little different question here, but a couple different questions about insurance. Can you talk about how you kind of approach this with your patients? So a couple different, I have Humana, I have private insurance, I have Medicare. Can you just talk about how that's addressed by you and how a surgeon would typically handle that?
Sure.
Is the procedure covered is the question.
Sure, of course. So regular question, we see this all the time. Thus far, we perform Lapiplasty procedures on patients that have all different types of major medical insurance as well as Medicare. The procedure is covered. We perform them in a hospital setting when necessary, only based upon patient health. And 99.9% of the time, these are being performed and covered in a surgical setting. And the insurance companies do cover it. Yes.
All right, thank you. If a patient had a specific question about their insurance, would they just go see their doctor, and would the doctor be the one that would typically kind of help them figure out whether it's covered or not?
Yeah, so it can be. So prior to surgery, our staff, and I would say that this is a pretty standard protocol, our staff will prior authorize all of the patient's procedures prior to the surgery itself. This way we'll have a very clear understanding as far as deductible, out-of-pocket, copay, so on and so forth. So the patient will have an understanding ahead of time as far as what the potential cost to them is, if there is any cost at all.
All right, great. A question from someone that's a smoker, and they're considering this procedure. It sounds like they're trying to quit smoking. Can you talk about your approach with smokers? And then their related question was, can I use a nicotine replacement?
Sure. So we encourage our patients to discontinue tobacco use because it has an effect on both soft tissue and bone healing. It can lead to complications such as infections. It can lead to tissues not healing. It can lead to problems with the bone fusing. So depending upon the frequency of tobacco use and the volume, that has a bearing on when we will say yes or no to a patient having the surgery. That's in my practice. Now, some doctors have a zero tolerance policy, and they'll say if you smoke one cigarette, you can't have it. We typically will monitor the patients. We get them together with their primary care doctor, work on a smoking cessation plan. That could involve the use of medication to curb cravings. It could involve the use of nicotine replacement, such as the patch. We discourage vaping, and we kind of work through the process with you. And some of it also is age related. So if you're older and you've been a long time smoker and you have problems with your blood flow to your limb, that may be an automatic no for the procedure. Again, health factors influencing. But if you're younger and you for little and you're going to put it on hold for a period of time, we may be a little bit more lenient with you, just kind of depending upon the circumstance. So it can vary. Some doctors, like I said, will have a zero tolerance policy with that, but that's a very good question to ask your surgeon ahead of time at the time of consultation.
All right, great. Related question about kind of pre-op conditions, but this particular patient was 59 years old and had a question of, how old is too old, and would it be worth it to get it done if I'm 59?
Well, as I continue to age, I think age is very relative. I like to still think I'm a young man, even though maybe I'm not. My kids tell me I'm old all the time, and they tell me that I'm growing a little long in the tooth. But 59 years old is probably our target population in general. That's when the great majority of patients are coming in to see us between 55 and 65. So that's actually a very good age to come in and have the procedure done. And I think that patients that age category would get a lot of benefit out of it.
All right, great, thank you. So related question, a patient described their condition and they really had kind of an extreme, so very severe bunion, crossover toes, extreme hammer toes. I guess if one surgeon had consulted and kind of recommended amputating one of the lesser toes. But in general, is there any severity of the bunion or other toes where you would consider, is it contraindicated because it's such a severe deformity?
I don't think that the procedure is contraindicated where you wouldn't want to do it, other than if the patient just has other health problems where their blood flow is just so terrible or their soft tissues were not going to potentially heal. Then in some cases, it's better to do a lesser procedure. I feel very confident that even with very severe bunions, we can correct those. We correct very severe bunions all the time. And in some cases, if the bunion has been let go so long and the patient has big toe joint arthritis, you may need to opt out and do a big toe joint fusion, but that still gets the toe straight, functional. It can be pain-free. You can wear your shoes, and then it also gives us the room to move the toes over and put them back into position. There are some mild risks or moderate risks, I would say, if you have a really bad, contracted, rigid, very bad crossover hammer toe where we correct it. You do tend to put a lot of stress on the small blood vessels that go to that digit, and they're very, very small. So sometimes, in very rare instances, you could develop problems with healing of that toe. So you do have to be very careful of that. So you have to pick your patients very carefully. But I think it's very doable, and we do it regularly.
All right, great. A couple kind of questions, all kind of the same theme about recovery. So we'll just kind of take one after the other here. Let's see. The first one is about, can I go back, a return to work question. So a nurse that's typically on their feet, would they be able to go back to work in 3 weeks, do you think?
I caution my nurses that 3 weeks may be enough, or it may not be enough, and it may be dependent upon how well they heal. Back to work, and she does physical therapy. She's up on her feet, and she was able to tolerate it quite well. Whereas in some cases, if you're having to lift and carry patients, support, that may be a contraindication to going back that quickly. So it would really kind of depend upon the physically demanding nature of their job. If you're not having to do direct patient lifting and care like that, then it's very feasible that you could go back. It just kind of depends upon your degree of patient involvement and your facility setting.
Got it. You mentioned physical therapy and Laura's job doing that, and in the image here, is physical therapy typical? Is it typically required by most surgeons, or how does that work after this procedure?
I send probably less than 5% of my patients to physical therapy, not because Laura doesn't do just an unbelievably phenomenal job with every patient that we send to her, but I just find that patients typically are fairly compliant. They do their range of motion exercises, and they're able to get back to doing the things they want to do without the need for therapy.
All right, great, thank you. Let's see. A question about the scar. And I know you showed some images of the scars, and those were, I believe, kind of a midterm kind of follow-up. Maybe talk about the scar. Is it a significant scar, and how long does it take to resolve?
We try to, in our practice, we try to provide our patients with the most cosmetically pleasing closure possible. We want them to have as little scar as possible. Some of us are more prone to scarring, so some of us can be hypertrophic scar formers or keloid formers. Some scars are a little bit more pigmented than others, but in general, we try to hide the scar, again, by using special stitching techniques to close the tissue. So that's a good question to ask whoever is going to perform you. How do you close the skin? What is your approach to minimize my scarring? What are your strategies if I do develop a scar? Those are all very good questions because everyone's protocol may be slightly different, but we try to close our patient's skin like a plastic surgeon knows any type of cosmetic procedure that they're doing for a patient to hide the scar.
Okay, thank you. And just in general, though, maybe for this procedure in the foot, I mean, maybe for even a more typical, closure, how long does it typically take for the scar to kind of, really resolve where it's not, noticeable anymore on the foot?
If you do have, let's say, a very mild scar, you may not even notice that scar after about 3 to 6 months at all. Or if you had a slightly larger scar or a more pigmented scar, it could maybe take up to 6 to 12 months, just depending.
Oh, great, thank you. A couple other post-op kind of questions. So can you remind when patients are returning to impact sports? There's a couple examples of I play pickleball, I run, I do things that were, impact sports. When are they typically returning to these impact sports?
If patients feel comfortable doing so, we allow them to return to those type of high impact activities at 4 months post-operatively.
Perfect. Question about patients that are overweight. Do you change your post-op protocol? Is it a longer recovery, or is it different for them if they're overweight?
Depending upon the severity of their weight, we typically do have some conversations regarding that, but we don't typically change the protocol, and we allow patients to walk immediately.
In the walking boot?
In the walking boot, and that's in my practice. So you may see a doctor that says, no, I don't want you to walk immediately on your foot, just because they may have some concerns. But we have a lot of experience with this, and we've had very good success with patients bearing weight in the boot in a protected fashion, in a limited fashion, and protecting themselves.
All right, great. A question about returning to high heels. Do you typically have any limitations on shoe wear for your patients once they've fully recovered?
Usually I'll allow my patients to return to high heels, well, a limited heel, I would say, excuse me, at 12 weeks, 3 months. So at the 3-month mark, I'll say you can wear maybe a 1/2 inch heel. And then by the time they hit the 4-month mark, when I release them the high impacts, I tell them they can wear whatever they want, that they feel comfortable wearing.
All right, great. A question about, you touched a little bit on, not typically doing bilateral procedures. So there's a question about that, of, not doing both at the same time. But can you specify how long you typically wait between the left foot and the right foot if you're doing them sequentially?
So the patients that we've done both feet, typically we make a 6-week delay. So we do the first foot, whether it's the right or the left. We allow the patient to have the initial postoperative protocol where they're wearing the boot for 6 weeks. And then when we transition the patients into their tennis shoes at week 6, then we'll allow for them to have the opposite foot performed so that they have that first surgical foot back in a shoe. As long as they're relatively pain-free and they're able to get around comfortably. And then we'll put them in a boot on the opposite side.
Great. Related question, so the patient that was considering, the knee replacement as well, how long would you wait after the bunion procedure to get something like the knee replacement done? Is it 6 weeks or is it longer?
I would say you should wait 4 months because the rigors of having a knee replacement and the need for appropriate physical therapy following knee replacement are of utmost importance. You have to be able to walk and carry your body weight after a knee replacement. It's very important for functionality of that joint after that is performed. And you're going to need to be able to work with your work at home and work with your therapist to kind of get you where you need to be. So I would say a good 4 months is key because you have no restrictions at that point.
Excellent. And when can a patient, I guess 2 questions, when can they shower and get their foot wet, and when can they swim in a pool?
So we allow patients to shower on day 5 following surgery. So we take their dressings down and we let them get it wet in the shower, but we don't let them soak it in the bathtub. And then I typically allow patients to begin swimming at week 6. And they can soak their foot at week 6, but not prior to.
All right, great. A question about the kind of the transition in the tennis shoes. You've mentioned tennis shoes at the 6-week mark. Is it just tennis shoes, or is, what kind of shoe wear is acceptable at that period of time?
Not to mention specific brands, but I typically like a good high-end running shoe and we usually go for about $100 mark, and when you're purchasing them. So one of the major running brands flagship shoes, that's kind of what we're shooting for, something that's going to be supportive and shock absorptive. We don't want like a pair of Converse or Keds or like a slip-on Skechers or something like that. We try to avoid those, not because they're not good shoes, but just immediately we want something that's a little bit more sturdy.
Got it. A couple of questions about, kind of follow up on the post-op part of it. So you mentioned that they get plates, hardware put in as part of the procedure. Does that set off metal detectors when they go to the airport?
It should not set off a metal detector. So the metal is made out of titanium, and it should be what we call non-ferromagnetic. So it should not register with the metal detector. And I have not had yet one patient tell me that they got wanded or stopped by the TSA because of their foot surgery. So that's a great question. That's a great, yeah, for many other reasons, but that is a very good question. We get asked that all the time.
All right. Another kind of related question is, I guess the question is, will the patients feel pain or issues around their foot with the hardware, with rainy weather or cold weather? I mean, is that, something you kind of hear about, but is that related to this procedure?
We don't usually get specific concerns about the hardware being in there, but initially, like when you start getting back to activity, especially the first like month 3, month 4, as you kind of increase gradually, there are some aches and pains and pangs and things that can kind of have to work their way out and shake out over time, because your foot was in a bad position for a long time and now it's tracking differently. So it's more supportive, the position, the joints are working a little bit different. It can kind of have an effect on the ankle and the Achilles tendon. Things are getting stretched out a little bit differently than maybe they were before. In a good way, things are moving the way they're supposed to be, but you're just not used to it yet. So you can have some aches and pains and kind of weird sensations. I don't know necessarily weather dependent, but we do get some reports of that, but those things usually resolve over time.
All right. Related to the hardware, you mentioned they're made out of titanium. Question about, how often or what happens if my body rejects the hardware? Can you talk about how common that is?
Well, I can tell you thus far, I cannot recall a patient that I've ever seen to date that has rejected titanium hardware. I'm not saying it's not possible, but Lapiplasty and the Lapiplasty hardware is not the only titanium hardware we place in patients. We use on a regular basis titanium plates and screws of all different kinds from all different companies for fixation of fractures, for fusions, all different types of orthopedic type issues. And I've never had to take titanium hardware out of any of my patients for a reaction.
All right, great, thank you. Down to the last couple of questions here. So a follow-up question about transitioning into shoes. You mentioned supportive tennis shoes. Specific question, what about clogs? This patient does not like tennis shoes. Would clogs fall in that category of acceptable?
Clogs don't fall in the category. Just so, especially like if you're thinking like kind of like a Dansko high arched clog, which are not bad shoes, but are kind of like slippage of the heel and like a pistoning motion of the foot back and forth in the shoe, and those are not the best. You definitely want something that has laces, and you definitely want something that is well padded. And clogs, even though I'm not anti-clog, it just doesn't fit the bill in this case.
Sounds like you're anti-clog.
No, I'm not. I have clogs.
All right, we're down to the last couple of questions here. So a couple more questions about particular conditions related or in conjunction with bunions. So one question about, I have high arches, and then
Sure.
kind of the opposite, a question that has flat feet. Can you talk about those conditions related to bunions and how you'd approach it?
Sure. So I think that's a really important conversation. Also, if you're going to have a bunion procedure performed, if you're going to have Lapiplasty, you can't ignore the rest of your foot anatomy. You have to pay attention to your foot, the way it's positioned on the floor, and any other combined deformities you may have. So patients, for instance, with flat foot, if you do Lapiplasty by itself, I think ultimately patients are going to be unhappy. So in our practice, if you have a flat foot, we tend to correct the flat foot and use Lapiplasty as a part of that that correction. So Lapiplasty becomes like a 1/3 of what we're doing, whereas we may need to lengthen the Achilles tendon, or we may need to lengthen the heel bone, or we may need to address heel position with, kind of cutting and shifting the heel bone a little bit. There are other things to take into consideration there to provide the patient with the very best optimized outcome. And in cases where patients have extremely high arches, if that also needs to be looked at and addressed, and you need to determine why the arch is so high, and if any other combined procedures need to be performed in order to get the best result possible. So you can't just say, well, every bunion, just do the Lapiplasty and they'll be fine. You have to look at the patient as a whole and kind of really identify what their needs are. So there could be a little bit more work that needs to get done in those patients.
All right, great, thank you. Then I guess just to kind of wrap it up here, well, there's more questions coming in now. A couple of related questions about surgeons going.
I don't know about Laura though.
Get some coffee. Some questions about patients going on the website searching for Lapiplasty trained surgeons, and a couple of related questions to that. How do I know my surgeon is good or experienced? Can you talk about that?
Sure. So currently in the United States, there are surgeons that are designated with the prestigious Centurion designation. So yeah, that they're indicated with a gold star. So I'm very proud to be amongst the surgeons. Then following that, surgeons that have performed at least 20 of the procedures appropriately are designated with silver star, and those are designated as excellence centers or centers of excellence. And then beyond that, those are the surgeons that are coming up, learning, and are innovative enough to start implementing those procedures in their practice. So it is very important to understand the level of skill of your surgeon and ask those questions. Have you done, how familiar are you with this procedure? At our practice, we have converted all of our bunion procedures strictly to Lapiplasty. We do not, in any case, do any other type of bunion procedure because we don't feel as if it's the correct thing for our patients. So we really do promote it, and we kind of live and breathe it. So to the point where my children walk around and discuss it with their friends at school and our neighbors. So really you want a surgeon that's fully adopted the procedure and is not just doing them here and there. You like someone who really fully appreciates and understands what the philosophy is that is Lapiplasty. So
excellent. Yeah, and like Dr. McAleer mentioned, if you go on that website and you search, if you haven't been there yet, you'll see their stars in different color stars that signify different levels of experience with the procedure. So you should be able to get a good idea of who the most experienced surgeons are in your local area when you do search. If you have any questions about your particular area or surgeons that are more experienced than others, you're welcome to email us as well. You have our email contact through this webinar. One question that I can answer here real quick is, how long has this procedure been performed? And we're coming up on almost 4 years since the first one, which was done in September of 2015. And Dr. McAleer, I think you've been doing it for several years now too. So this is the last question here. Should there not be any more typed in? How soon can a patient fly or travel, in an airplane after the procedure?
Yeah, that's a good question, because with any type of extremity surgery, there's always some increased risk for developing a DVT, which is a clot in the leg. But sitting on an airplane for, let's say, a transcontinental flight or an international flight, or even a short hop for a couple of hours, that puts a lot of stress on your body. Walking through airports, sitting for prolonged periods of time, keeping your foot down in a dependent position below the level of the heart, your waist, which can increase swelling. So we try to encourage our patients when they're having these procedures to avoid flying for up to 12 weeks. But I do have patients that do fly at 6 weeks. Sometimes I'm not so happy about it, but sometimes duty calls, family obligation, work, so on and so forth come up. But we try to keep it to 12 weeks if possible.
All right, great. All right, so I promise this is the last question, and then we'll wrap it up here tonight. This is a quick one. So what's the youngest age that you perform this procedure?
Currently in my practice, now it's FDA cleared to have to perform this procedure for patients that are 12 years plus. However, in my practice and in my experience, the youngest patient that I have currently, I believe, is 15 years old that I did this for.
All right, great. And that you're looking to like close growth plates. Is that kind of why you're not going to younger patients than kind of that 15 years age?
Exactly. And so if a patient has open growth plate, which is the center of where the bone is growing, disrupt that growth through this process. So we don't want to invade that area until the bone is fully mature. And so we determine if that bone is mature based upon X-rays. And after that, and we determine what the patient's bone age is, and if the growth plates are closed, then we can safely proceed.
All right. Well, great. No, that was excellent, and I promise that's the last question. So if people have questions on here that did not get answered tonight, we're happy to facilitate getting those questions answered. I think we tried to get to all of them, and I really do appreciate Dr. McAleer all your time here tonight. I always learn something hearing you answer questions and hearing you lecture, so that was incredible, and we really appreciate your time here tonight, and Laura, your experience here as well. So with that, thank you, Dr. McAleer. Thank you, Laura. And, everyone that was on the webinar here tonight, the follow-up will be you'll receive another email from us with the recording of the webinar. So if you missed a portion of it or you want to go back and listen to other parts of it, you'll get a recording. And like we said, if you have any questions about finding a local surgeon, questions about the procedure, feel free to email us, and we're happy to help get those questions answered. So thank you, guys, and everyone have a great night.
Yeah, thank you, everybody, for attending.